Good afternoon. Welcome to another Medical Grand Rounds. I'm Bob Wachter. I'm chair of the UCSF Department of Medicine. Welcome to our live audience from our department and our colleagues here at UCSF, to our partners at the UCSF Health Network, and to all others who are joining us. We'll post this video, as is our tradition, at about 7:30 tonight on YouTube, and our previous Grand Rounds have been viewed over 250,000 times. A few ground rules for the live audience are here. You'll be on mute throughout. If you have questions, put them in the Q&A box. My colleague Quinny Chang is monitoring them and try to get to some of them. As I said, this session will be recorded and up on YouTube later. Today we have two main segments. The first will begin with a George Rutherford update on the state of the epidemic. Where are we now that we've begun to open up in all sorts of different ways around the country? We'll talk a little bit about the protests, and we'll talk about what the WHO was thinking on Monday and unthinking on Tuesday with their pronouncement, which confused a lot of people. George, as you know, is a professor of epidemiology and biostatistics and our lead person when it comes to modeling and the epidemiology of the epidemic, and he has taught us all a tremendous amount. After George finishes, he'll stay on, and I'll bring on three other experts to explore a truly complex and really central issue, which is the balance between safety and speed in the pandemic. In the face of a pandemic, it's logical and actually even essential to move faster. But just like driving above the speed limit, you may get to your destination faster, but you also increase the risks of an accident. And what we are seeing is a relaxing of the speed limits along with the research in COVID. The normal process for getting a study up and running, getting the results analyzed, and then getting them published in a peer-reviewed journal simply won't do, given the importance of the disease as well as the effect on the economy. So the traditional publication process has begun moving at hyperspeed. And in a world of social media and the internet, the traditional peer review process is only one way that research comes to see the light of day. So we've come to see publication by Twitter, by press release, by press leaks, and almost standard now by non-peer-reviewed preprints. And we've learned that even peer review is no guarantee of getting it right, as we saw two articles retracted from two of the top journals in the world, the New England Journal and Lancet, just last week. And then after the research, or during the research, there's the FDA charged with ensuring that new drugs and devices are safe and effective. Again, completely understandably, given the impact of COVID, the FDA has also tilted towards speed. A number of antibody tests were approved with minimal review, and several of them proved to be inaccurate. Hydroxychloroquine was made generally available for use in COVID in the absence of any evidence of effectiveness. And of course, the real tests are still to come as the FDA has to weigh in on any number of new therapeutics and ultimately, we hope, vaccines. So we've assembled three world-class speakers to join George, who is also world-class, for a discussion of these rich and complex issues. I'll introduce them now, and then they will come back again in about 20 minutes at the completion of George's discussion. The first is Rob Califf. Rob is best known as having been a UCSF resident, but he's also gone on to other accomplishments, including founding the Duke Clinical Research Institute and serving as FDA commissioner under President Obama. And I should note that the current FDA commissioner, Steve Hahn, is also another former UCSF resident. He's now the director of medical strategy and policy for Verily Life Sciences and Google Health, both alphabet companies. And Rob, welcome, and thanks for being here, and welcome to Northern California. Next is Vinny Prasad, another new member of the UCSF family. Vinny just joined us last month. He's an associate professor in the UCSF Department of Epidemiology and Biostatistics. He has a secondary appointment in our department in oncology. Vinny's research is focused on cancer therapeutics, health policy, and evidence-based medicine. And he's widely known, and I think he will accept this, as an iconoclast and a frequent critic of conflicts of interest and drug approvals that may not be supported by robust evidence. He's author of two important books, one Ending Medical Reversal, and another just came out called Malignant: Bad Policy and Bad Evidence Harm People with Cancer. He also hosts the podcast Plenary Session. And for many of us, this is our first chance to welcome you to UCSF, so we're thrilled that you're here. The third is not new to UCSF. Rita Redberg is professor of medicine in our Division of Cardiology and editor of JAMA Internal Medicine. Rita is a world-known leader in technology assessment and preventative cardiology. Her editorship of JAMA Internal Medicine has been extraordinary. The journal has reached new heights with a number of innovative features, including ones that raise issues around the use of evidence for drugs and in research. Under her leadership, JAMA Internal Medicine's impact factor has gone from about 10 to 21, which is an unprecedented increase in impact and influence. So we will bring those three speakers, Rob, Vinay, and Rita, back in about 20 minutes after George tells us about the current state of the epidemic and where things are going. So George, welcome.
Thanks very much, Bob. It's a pleasure to be back. And I have a few slides, as you might imagine. May I have the first one, please? So worldwide, there's almost 7.5 million cases of COVID that have been reported and 418,000 deaths. In the US, we're approaching the 2 million mark in cases and have exceeded 110,000 deaths. As you can see from these graphs, we have a kind of semi-declining, plateauing epidemic curve. These are just reported cases, and for deaths, a slow decline. The next one, please. If you look across the United States, these are cases in the last 2 weeks. Red means rising, and you can see this broad swath across the Southeast that continues to see rising cases, plus the upper Midwest with new clusters in Indiana, and then as well in parts of the Minnesota, Iowa, and less so now, but also in the Imperial Valley of California and a small bit in Kings County. The next one, please. The New York Times every day publishes a kind of who's winning, who's losing page, and this is today's with where cases are increasing as of today. Not only us, which reflects what's going on largely in Los Angeles, but also to a certain extent in the Central Valley, and I'll get to that in a second. But also a number of other states. Many of these states reopened early. The ones that were somewhat more cautious, Washington, Oregon, North Carolina, and New Mexico still have rising rates. Where cases are decreasing, you can see those here, but I circled 2, Minnesota and Washington, D.C., understanding that D.C. is not a state. But these are the sites of the recent, 2 of the earliest sites of protests over the George Floyd murder, and we're seeing that those rates are continuing to decline there, and so we have not yet seen spikes up because of the protests. I think that would be where we'd see them first. The next one, please. In California, we've had 134,000 cases and 4,653 deaths. The numbers of cases in California continue to rise, again, largely driven by Los Angeles, where deaths have plateaued, and we're currently running around 60 deaths per day. If you think back to the last slide, nationally, it's somewhere closer to 1,000 deaths a day. So if you think of California as representing about 12% of all people in the United States, 50 or 60 is about half of what our fair share should have been. So we're ahead of the game. The next one, please. And this divergence, I think, between cases and deaths would suggest that, first of all, deaths lag behind the cases by a couple of weeks, but it may suggest that we're seeing better diagnostics among younger people and people who are less likely to get sick and have to be hospitalized, although there is tremendous pressure on the hospital system. This is some new thing that I've been able to put up. On the left are total cases by county per 100,000. But on the right are represents what's happened in the last couple of weeks. So you can see outbreaks in Imperial County, ongoing transmission in Los Angeles, Kings County, where the Hanford where meatpacking plant had gone on, and there had been previously been an outbreak here in Del Norte, which is where one of the major state prisons is as well. But you get this sense that there's a lot of density down here in the lower San Joaquin Valley as well as in Southern California. The next one, please. Here in the Bay Area, we've had 16,000 cases and 478 deaths. These are single digits. These are a 7-day moving average. This line is 5 deaths per day in the Bay Area. So you can see that every death obviously is tragic and leaves behind families and loved ones. But relative to the nation, we have many fewer deaths than we should be, than would have been our fair share. And I think that's a testament to not only medical care, but our ability to keep pressures off the ICU. However, back here in case count land, you can see that this was our original surge, and now we're kind of leveling off here at a higher level of around 220 or so cases per day, representing a lot of new transmission in counties like Marin and Alameda and Napa, where there have been outbreaks among younger blue-collar workers from low-income neighborhoods. The next one, please. This is the famous lag I've been told about. Here we are. In San Francisco, you can see we have these, these are 7-day moving averages again. Here is our initial peaks out here in mid-April with declines, a couple of peaks in here coinciding with improved case finding really more than anything else in the Mission District through Diane Havler's study, and also some outbreaks in homeless shelters. But we're seeing kind of a general plateauing, I think that's fair, or maybe a slight decline. But we're still seeing in the 20s to 30s of new reported cases each day. The next one, please. And as promised in the Central Valley, there is a large number of cases, and it's they show up in odd places at odd points in time. And this orange here is Fresno, but you can see outbreaks in some of the other counties as well. Now maybe there's kind of an unexpected number of new cases in Stanislaus County as well, which is where Modesto is. I knew I'd pull that one out. The next one, please. Now, the pot got stirred on Monday when the World Health Organization put out its new advice on the use of masks, which was not particularly helpful. But as part of that, there was a statement that said, comprehensive studies on transmission from asymptomatic individuals are difficult to conduct, but the available evidence from contact tracing reported by member states suggests that asymptomatically infected individuals are much less likely to transmit the virus than those who develop symptoms, not referenced. So in your context of preprints, here's something that's even a pre-preprint. The next one, please. So I thought I'd review this evidence, and let's think about 3 questions about asymptomatic infection. How common is it? How transmissible is SARS-CoV-2 infection from someone who has no symptoms? And what is the population attributable fraction of transmission from people with asymptomatic infection? The next one, please. There have been a couple of recent meta-analyses that have looked at this question. Here's one that's recently come out that came down squarely on the proportion being somewhere between 40 and 45% of all infections being asymptomatic. The trick with asymptomatic infection, and I think the trap that WHO may have stepped into, is that is that when we say asymptomatic infection, we really mean people who are asymptomatic for the entire period of their illness. But if you look at it cross-sectionally, it's going to include people who will go on to develop symptoms. That is, they're pre-symptomatic. We know that people are infectious for a couple of days before they develop symptoms. So the real kind of important public health question is the cross-sectional question about how many people have no symptoms and can transmit. And that's one of the things that underlies the advice about masks. Next one, please. Here in another differently done meta-analysis from Australia, they came up with a proportion of 15%. And this is going to be a, kind of one of these classic exercises in epidemiology going forward, compare and contrast these two studies and how they came out with such different numbers. But again, the point is that this is not a rare phenomenon. The next one, please. Then if we ask the question, how transmissible is infection from someone who has no symptoms, meaning both pre-symptomatic and asymptomatic? One thing is, do they have different viral loads? And I would point out that in studying outbreaks in a nursing home outbreak in the Seattle area, viable virus was isolated from long-term care residents with no symptoms. And in a couple of other studies, they've also looked at it and found that the cycle times, the PCR cycle times, which is a proxy for viral load, were similar. And over here you can see on this right-hand panel that the red circles are positive cultures and the diamonds are negative cultures and the X's are no cultures. If you see people who are asymptomatic, and then look on the x-axis is the cycle times. So it's like golf. So low cycle times means there's a lot of virus present. High cycle times means there's very little present. And you can see that people who are pre-symptomatic, these 24 people in here, look very much in terms of cycle times like people with atypical symptoms and typical symptoms. So I think we have to assume that people who are pre-symptomatic, and even a few that are asymptomatic, and see here's one person from whom viable virus was recovered, are as likely to transmit or could potentially have similar viral loads as people who are symptomatic. Now, is transmission likelihood is higher when someone's coughing or sneezing, but can occur when talking. And there's a great preprint from Jeremy Howard that really heavily summarizes encyclopedically summarizes the masking literature. And one of the reasons that you could think of people with symptoms being more infectious is because they cough and sneeze. Now, what we're trying to achieve with masking is, because people who are coughing and sneezing are supposed to stay home, what we're trying to do is cut down on transmission from people who are talking. And so the masks seem to do a good job of that. If they're coughing or sneezing, they're going to have more expulsion of, even if the viral loads are similar. And then the next one, please. Here's a summary of risk of SARS-CoV transmission by the presence of symptoms. And you can see, if you look down here, just summing these up, that people who were asymptomatic at the time they were tested in these 4 studies were transmitted about 1.5% of the time, and people who were symptomatic transmitted about 3% of the time. So people who were symptomatic were twice as likely, again, not surprising given the fact that they're coughing and sneezing. And the next one, please. And this is a paper that when you read it, it looks like reading a, sort of that last quarter of calculus textbook. But this is from a group that modeled this in Wuhan. And the kind of translation of all this is that undocumented people, meaning that they're undiagnosed and unreported, presumably because they're mildly symptomatic or asymptomatic, were about half as infectious as people who had been diagnosed, reported, documented in this jargon. But because there were more of them in China, this is a population attributable risk, they accounted for 79% of all modeled 79% of all documented cases. So this is not a trivial problem, asymptomatic and pre-symptomatic transmission. The next one, please. So the conclusions here are asymptomatic and pre-symptomatic infection are very real and they're very common, and the solution is to wear your mask. And the next one, please. So Dr. Wachter, having blown my punchline, the next morning, this is Tuesday, WHO walked back and on this assertion that asymptomatic transmission is very rare, saying that it was a misunderstanding to say the asymptomatic transmission was rare globally. The next one, please. So you got to take this stuff seriously. Now, I'm going to use my 2 minutes of fame here to advertise for a study that we're undertaking among healthcare workers, and we're doing this with Stanford and Sarah Dornberg at Moffitt and Vivek Jain at Zuckerberg San Francisco General are the site PIs. You will, when you get home, get back to your offices, you'll see that you should have email in your inboxes where we're seeking to find hospital workers like you at our institutions. Please, if you're calling in from UCLA, don't call us. To understand the infection and immune responses. The next one, please. This is called the chart study. There's the QR code for people who understand how to do this. Don't look at me. There's an email that'll get you to it. And the next one, please. And if anybody's listening from Stanford, the Marissa Hollabar is the contact there. This is going to be, we're going to follow people over 3 months and then longer to look for serological conversion. And then if we find people who are infected, we'll follow them more closely, again, trying to understand antibody responses and re-exposures going forward over time. We're trying to get short visits. We're trying to get an actual site at Moffitt. And for those of you at the General, there will be a site at the General. Thanks very much.
Thank you, George. As usual, great and fascinating. So I could go forever, but let's just take 5 minutes of questions before we bring on the others. Is the virus getting milder? You hear that out there, that it's mutated and it's milder and people are not getting as sick and all that. Is there any evidence of that?
No, there's no evidence of that. Listen, but you have to realize the virus doesn't watch TV, doesn't watch Fox, it doesn't watch CNN, it doesn't read the paper, it doesn't listen to what everybody's doing, it doesn't follow restaurant reopenings. It has one purpose in life, and that's to reproduce in you. And I think the more you wrap your head around that, the safer we'll all be. And then,
of course, everything has become politicized here. You look at the breakouts, and they're happening to some extent in states that opened up earlier, but you can also find states that opened up and seem to be doing fine. So what explains the variation?
It's variation, and it has to do with exposures, and probably some degree of luck. But I'm interested in states like Georgia, which clearly opened up earlier than they probably should have and seem to be getting away with it so far. There are other states that have done absolutely everything correctly, like New Mexico, that seem to be taking a beating now. And then there are others, and I almost put in this great slide I have of people in Scottsdale, Arizona, in a 2-story bar on Memorial Day, packed in cheek to jowl with not a single mask in sight. There's, what a surprise, a big uptick in cases in Arizona following Memorial Day. What we haven't seen, as I said, we haven't really seen a lot of disease or any disease so far in the big statistics that we might be able to ascribe to the protest movements. all over. There have been cases reported among National Guard troops as of this morning.
Is it too early to be seeing a big uptick from the protests?
I think we might, it's pushing it. It's, think about, maybe 7 days post-exposure as we'd start seeing cases going up.
Yeah.
And we haven't seen that. It's more like, now it's been more like 14 days. So, they were outside, which is good. A lot of people had masks on, especially in the West, which is good. Tear gas is bad. Shouting's bad. And, it's all balancing things, right?
You and Mike Reed was on last month talking about the whole contact tracing thing and an army out there to do it. We haven't heard much about it. Is it happening now?
Oh yeah, absolutely. And it's, we're trying to work out metrics. Everybody wants it to be 90, 90, 90, but sort of it really needs to be 90, 90, 90, 90, 90. There's lots of 90s. So, we want to be able to find 90% of the interviewed 90% of the cases, find 90% of the named contacts, test 90% of them, of those who test positive, make sure 90% of them get into isolation. Those are the kinds of metrics we're dealing with. And I got off a big national call on contact tracing to come in here. We are so far out in front of everybody else. It's not funny.
Good to hear for us. You talked a few weeks ago about the kids and the fact that they don't seem to be getting all that sick, and they also don't seem to spread it to adults that often. And that thinking, I think, has led to sort of more enthusiasm for opening schools than there might have been otherwise in camps. And then we hear about a big breakout in Israel and in schools. So what's going on?
In high schools.
In high schools. So
high schools.
High schools different than younger?
We've yet to see an outbreak in an elementary school that I'm aware of. We've known that high schools can have outbreaks. There was a big outbreak in the Haute-Savoie in France earlier on. High school kids, there's no difference between high school kids and the sailors on the Theodore Roosevelt, except half are female, I guess. So it's going to be, there's going to be pretty easily transmissible among them. And so that's the real challenge, is how do you pull off high schools? How do you pull off colleges? Keep social distancing, get people to wear masks, and really stop transmission there. The elementary schools, we may be getting a freebie because it's transmission's less. It would seem, based on a fraction of evidence, that transmission may be less likely in younger children. But you're going to have to sort of assume that there is going to be transmission, and this Kawasaki-like syndrome sort of even tips the balance further to being more conservative about how you arrange schools.
All right, maybe last question, then we'll bring on the others. You can be as political about this answer as you want, but as we think about opening up big things, one big thing that appears to be opening up are some political rallies and maybe one political convention. I can tell by the look on your face that you don't think that's a good idea, but go ahead and talk.
Why are we doing that when we could open up college football instead?
Yeah.
Let's get our priorities straight. Unless everybody's wearing masks and are socially distanced, it's not a great idea. As I said, the virus doesn't watch television. It will go to political conventions. And, you're going to get problems from things like that. And, if we can get 3 outbreaks from Mother's Day picnics in Santa Cruz, imagine having a convention hall filled with a zillion people yelling and shouting without masks.
People have a hard time understanding why now a group of 10 is okay. Let's assume it is, and a group of 20,000 at the same distance, assuming that is not okay. So what is it about the number that's so bad?
Well, you have a higher probability of coming into contact with someone who's infectious, right? If we're dealing in the Bay Area with a prevalence of, say, 1 or 2%, and not all of those people are going to be infectious, we're dealing with a relatively small probability of coming into contact with someone. If you go to a place and put a zillion people in it, it's going to be, a zillion divided by whatever the national prevalence of infectiousness is. And there are going to be enough people there that can infect others.
Yeah. Okay, great. Thank you. So it looks like that one convention may very well be in Jacksonville, Florida. That's the latest news. Let's bring on the others. Let's bring on Rob, Vinay, and Rita. Welcome, everybody. I don't see Rita on yet. There she is. All right. Rita, why don't we ask you to start? So we're toggling here to discussing the sort of tension between speed and getting it right in COVID. So take us through the journal editing and publishing process, not in painful detail, but relatively quickly. Sort of, how do you think about that balance on a normal day, and then how do you think about that balance during a pandemic? And you're on mute. There you go.
And I will just say, I, like many of you, have not had a normal day since coronavirus started. But I mean, I think it's good, just a quick reminder of the mission. You know, our mission at medical journals in general, and certainly JAMA Internal Medicine, is to publish high quality science that can help doctors take care of patients better. And that means, you know, suggesting things that are helpful and suggesting what we should avoid because they're not helpful. And to do that, you know, we have a very high rate of what we call desk rejects. So probably you got the letter, you know, it didn't go to review and we rejected it. And we do that as a point of efficiency, just to turn things around quickly, because I have a great group of editors. We've worked together for a long time and we have a good sense of what will make it through peer review. But then generally we always send articles that we think are potentially interesting and will have an impact to peer review. That process on the median is 35 days for us last year. That's probably about average for most journals. I mean, we certainly work hard to turn things around quickly. The time from receipt to first decision, if it's a reject, is 2 days. So it's, you know, nothing stays with us a long time. And with the review, as I said, it's 35. So certainly with coronavirus, our submissions, like many journals, have tripled. You know, so where I was seeing about 250 submissions a month, the last few months, it's been 900. I have the same staff. In fact, I have fewer staff because some people have been pulled into 24/7 coronavirus work, and we're turning things over. And on top of that, just about every COVID submission comes with the request to have it reviewed yesterday and published last week. And so, you know, we're of course still trying to maintain our mission, but there's hard to ignore the pressure that everyone feels to get important things out there to help people. And so, you know, in striking that balance, what we've done is we've maintained peer review, but we are leaning on peer reviewers to turn things around in a week instead of the usual 2 weeks. Sometimes, as George knows, we ask our colleagues to review things kind of instead of, you know, sending them out to peer reviewers, but we're very much dependent on that. The editors are all turning things around quickly, but we're still doing our peer review. And then of course, once it's accepted, the staff in Chicago at JAMA are working really hard to get everything published as quickly as possible.
Right. And maybe one more for you before we move on. The whole preprint thing kind of just came up one day. I remember it not being a thing. I remember the Engelfinger rule, do not have this thing see the light of day before it shows up in the journal. And all of a sudden, everything is seeing the light of day before it shows up. So how do you think about that?
It's a big issue, as you said. The thing about preprints, I think they started in the biomedical sciences where people wanted to get other scientists' comment on their articles. And I think for that, it can be helpful. But I think they should have a big watermark on them that say, not for clinical use, not for prime time, certainly not for therapies, because it's a big problem. I mean, people are very anxious to get work out there, but the work on preprint servers, which as you said, has really tripled. And the last data I saw on medRxiv, only 20% actually get published in an actual journal. They haven't gone through peer review, and it's very hard to know if they're reliable or not. And I do have colleagues who have told me they have patients who pull things off of the preprint servers and come in and say, I want this drug. And that's a big problem. It's very hard to rush that process. And I think they have value in if they can get ideas out there that people then take through the rigorous process of a scientific study.
But when you see an article that comes to you that's been a preprint, does that change your thinking about it, or it doesn't prejudice you against it at these days?
It doesn't prejudice us, but we do, if asked, our policy is we discourage preprint servers. We don't forbid them, but we discourage them.
Got it. All right, maybe I'll go to Vinay next, and then I'll go to Rob, because we'll talk about the publication thing for a minute and then move to the FDA. Now, you sent me a list this morning of the of articles and research studies for which there have been problems in COVID. And it was a wide variety of things that came out in a whole bunch of different ways. And you've written a book about findings that later proved not to be correct, in part because of flaws in the process. So maybe take us through a few examples there, and then just how you are thinking about the publication process today in a world of a pandemic.
Well, thanks for having me, and I'll be happy to do that. So I guess, I kind of crowdsourced it yesterday on Twitter and asked for people to kind of add to the list. But there have been a number of, I think, notable errors or maybe miscommunications of fact that have appeared both in the preprint side as well as in some traditional publications. One classic that comes to mind is the New England Journal Remdesivir Compassionate Use. The original paper had an error in the Kaplan-Meier plot and thus sort of artificially estimated that the improvement rate was a little bit higher than what it actually was. They censored people who had died, which is a classic error of making such a figure. There've been a number of other sort of preprints that make you scratch your head, preprints that have suggested that smoking is actually protective. Of course, that made a classic fallacy called the Table 2 fallacy. There's another article that came out that suggested alopecia among men was a risk factor for severe COVID, but they didn't adjust for age. And so, that's sort of a classic potential confounder there.
Me a little scared there.
So, I think what this all makes me think about is something that people are very eager to discuss, which is COVID-19 something fundamentally different? Is the rate of missteps, of misstatements higher than what we'd expect? Or is it the same rate, but we're just seeing it more visibly because we're so attentive to the news and because the time span has been compressed so dramatically? And I think as an empiricist, as a researcher, I withhold judgment. I'd like to see some good studies, and I bet in the next year or so, there will be such studies that will evaluate that claim.
Yeah. Talk for a minute. One of the studies that came up was the Santa Clara antibody study, which came out in preprint, and struck me as it received one of the most vigorous peer reviews I've ever seen, but it was on Twitter. So, do you think Twitter is a self-correcting mechanism in this environment?
Well, that's a great question. I guess I would say I will admit to having evolving and I think sort of ambivalent views about this. I think many of us who have long sought to correct published journal articles have been a bit frustrated by the low rate of acceptance of letters to the editor. There have been many sort of fantastic points or criticism that due to length and space requirements were simply not taken. I think a number of researchers may be even more frustrated by some journals. I don't want to name them, but they have only 125, 150 word maximum letters to the editor. That's a very short space to get a point across. Twitter and social media, I think, has emerged as a great public forum for the criticism, for the thoughtful commentary on clinical studies, research studies of all sort. There have been some Twitter commentary that I think rivals even published journal articles in terms of depth and sort of skill of analysis. In this particular case, I think you've picked perhaps what has been one of the most polarizing discussions, which is the Santa Clara study and the authors of that study. And I think part of the reason why that's generated so much interest is that the authors of that study had at other points in time articulated some sentiment that made us want to ask tough questions about or perhaps even rethink the lockdowns. And because they had maybe put a flag on themselves as having a view on that very loaded and heated topic, that study, I think, underwent many, many eyeballs on it, and it was criticized very vigorously, some of which I think is very fair criticism, some of which I thought might have crossed a line in terms of tone and in terms of speculation about motives. So I think we're going to learn a lot more about that study. It's still under the microscope.
Great. All right, Rob, ultimately, the FDA is probably the most important judge here of what works and what doesn't. So when you became, and one of the things that strikes me that when you become FDA commissioner, one of the things you have to do is sort of figure out where you want that dial to be between speed and safety. So how did you think about that when you became FDA commissioner, and then how do you think it's working out now?
Bob, thanks for having me on, but let me raise an objection to start with. I I love the FDA, but I don't want to be put in an FDA box. I've probably submitted more journal articles that have been rejected more by Rita's operation than almost anyone else. And, also practiced medicine for many years. So I have a lot of different views on this. But to your question, I'd first point out the FDA commissioner doesn't set the dial. Evaluation of medical products is done by civil servants, and the top of that heap is the center director. So for drugs, biologics, devices, it's really the civil service that makes those determinations. The FDA commissioner, of course, has a major role when it comes to policy, which does generally have an impact on the dial over time. But when people think about individual medical products, it's really the centers and their full-time government employees who make those decisions. And so you asked me about when I came in. It was an interesting time because 21st Century Cures was on the hopper, and the user fee agreements, which pay for really the majority of FDA work now, which are 5-year agreements with major input from consumer groups and patient advocacy groups, and then put into law by Congress about how things are going to be. And I think it's fair to say the public through Congress had said that in certain circumstances, they thought the FDA was too slow. This mostly related, literally taken, to diseases without effective treatments and with a high risk of death. And there was a real consensus that there should be an allowance for earlier use of those therapies because people were willing to take that risk. That, I think, was pretty carefully vetted. Question comes when you try to extend that beyond that point. And, I'm sure we could have a long conversation about those issues, but I was certainly in agreement with that general concept that where people with diseases said we're willing to take the risk, that should be done. And then there was this major issue about post-market evaluation, which is part of that law. And I'd say has been suboptimal and remains suboptimal today.
So I'll take you out of your FDA hat for a second and put you in your current hat, which is really atop the healthcare world at one of the great tech companies in the universe. As you've seen sort of how Google works and Verily works, and you think about the current world of digital healthcare, do you see this process of evaluating treatments and judging whether they work and post-market surveillance and mining data from EHRs, do you see that now in a new light from what you've seen the capacity is? I mean, you're closer to that than anybody in the world right now.
Well, I mean, what I'd say, I guess I got too old before I came into the Alphabet universe because I had certain views from all the interactions I'd had, and I'm at risk of just solidifying the views I already had, and that's basically what's happened. I mean, most people, when they think about a treatment, don't rely on JAMA or what Vinay may say on Twitter. They use YouTube and Google search and word of mouth. And even when it comes to their doctors now, they're very often relying on other sources because the doctor or the nurse only has a very limited time. You can almost literally feel as people are leaving your clinics at UCSF, they're feverishly searching to try to figure out what the hell you were talking about because they were under stress, you had limited time, you were looking at your computer, all these things that you've written about, Bob. So I think that's point number one. But point number two is the possibilities are really amazing for what we could do with really evaluating therapies in real life using real world data, that is data from the real world, but not shabby methods. The methods still need to be good. And I do want to sort of throw it back now that I'm no longer in academics. The major impediment right now is the health systems. The main problem is not that people don't want to participate in better studies, it's that they're not being asked by their doctors and nurses and others they rely on. In fact, there's almost an avoidance of participation right now, particularly in the US by the medical establishment.
What do you think's behind that?
Well, you mentioned that when we were talking earlier, you said you had a volume-driven institution. And so, you know, what we hear, and now in my work at Alphabet, I have a chance to look at a lot of data about what people think. And it's definitely throughout America, clinicians feel under siege. They're burned out, you know, that term. When it comes to getting like consent for participation in research, they don't have the time. No one pays them to do it.
Mm-hmm.
And it raises questions about uncertainty that people are very uncomfortable with. Like, maybe if you said you're uncertain, the patient would want to go to Stanford where someone has the answer already and knows what to do. So, I think it's great to critique the work that's been done, but to me, the biggest problem we have right now is not enough people are actually doing the work.
Yeah, yeah. And as you've looked at the capabilities of AI down the road and better interoperability, are you enthusiastic about the real world evidence thing, or do you feel like that the methods are not going to be rigorous enough and we're going to get some crummy? It's facile. You can press a couple buttons and say it looks like drug A works better than drug B, but it's sort of garbage in, garbage out.
Yeah, you know, I've been doing this since 1976 when I did my first Duke database real world comparison of therapeutics, and you get the wrong answer about half the time, but you don't know which half. But so and Bob, you said something that I really, really want to comment on. I am highly enthusiastic about real world data. The idea that you can draw the right inference about therapeutics, particularly when you're going to apply that therapeutic in a population from a rarefied research clinic, is just, you know, only partially true. So as data gets better and better in electronic health records and patient-reported outcomes, real-world data is just going to get better and better. But there is no substitute for good methods. So real-world data doesn't become real-world evidence until you apply a method. And very importantly to the FDA, when we put 21st century cures, you know, through the hopper, it says in there very clearly, randomization is the most important method to use applied to real world data. So for example, if the University of California system randomized more often using its electronic health record system, we'd be really smart, but you almost never do it.
Yeah.
And the idea that someone can push a button and get an answer from a database. Well, I think we saw the result of that in some of our most prestigious medical journals recently.
Yeah.
So let's take advantage of real world data and the huge populations that exist and the fact that people actually want to participate in research. And let's let the leaders of medicine, people like you, get your people to work generating evidence instead of just critiquing it or feeling like if they don't generate RVUs, they're going to get a call from the division chief saying your salary's cut and who cares about research? You got to generate income.
All right. Thank you. I think it's a really important point. George, welcome back. You're obviously a major producer of research, but you're also, every presentation, you're a consumer of research. Anything that struck you as you've been watching the last three or 4 months of research data coming out that as you think about this sort of balance between speed and getting it right? Because there's a ton of stuff coming out very fast and sometimes it's wrong.
Yeah, well, you know, I have to say that sitting down every morning with 50 preprints that I have to peer review myself is not particularly helpful. I would like some help digesting those. And I realize preprints may have been a kind of a thing before in basic science, but in my world, it's a new feature, and I find them occasionally I find them fairly regularly informative, but again, you know, I'm suspicious of them, and I'm very careful about what I pass on.
Would you rather a world that didn't have them, or are you arguing that there needs to be peer review of preprints, and if there is, that's called a journal, right?
Yeah, that's right. I just wish that that Rita would turn the switch and move JAMA to light speed and and plow through these, and basically, have a 1-day turnaround on peer review. That, of course, that I don't want to do myself. But.
Yeah. But net, you think it's positive, the fact that you are, because if there were no preprints, you would be waiting another month or 2 months or 6 months.
Yeah, or you'd be like WHO and just say stuff like, well, everybody says that.
Yeah.
Member states say that, ... Therefore, we've reached the conclusion that this is absurd to do this. Like, what?
Yeah. Okay. And maybe turn to Vinay. As you've critiqued the existing system, and now the existing system's in hyperdrive. So run through kind of what you think the main flaws with the existing system of peer review are, because we're talking about now systems that maybe are even more error prone than the gold standard, but you've worried about the gold standard.
Yeah, maybe let me talk about, I think, the regulatory side and then the situation we have with therapeutics, and then let me come back to the publication question. I've been, I believe I've noted that over the last 15 years or so, I think we've seen an increased appetite for uncertainty at the time of regulatory approval for drugs and drug products. And we, as Dr. Califf mentioned, had initially been promised that for many of these products for which we don't know when they're approved, if they make people live longer or live better, that post-market we will learn those two facts. But a number of empirical studies have shown that post-market knowledge is very, very weak. It's a broken process. So the net result is, say in a field like my field, cancer medicine, we have a third of drugs coming to the market with no control arm, 2/3 coming to the market based on a surrogate endpoint, and even 5 years on the market, we only know they improve survival in maybe 10% of those drugs. At the same time, we are now climbing past 2 million cases of COVID-19 in this country alone. And I estimate from a back of the envelope calculation that maybe we've put about single-digit percentage points of patients on randomized controlled trials to figure out what actually works and what doesn't. And I believe that part of the reason why our infrastructure is so poor at randomization, which would have settled many of these questions, like hydroxychloroquine, we could have settled a month and a half ago. Remdesivir, we could have had the answer to that in a very prompt manner. I believe it's because we have devolved and broken down these systems under the traditional model. We accept so many new drugs, and the capital in pharmaceutical industry has flown to pharma, to cancer, and to rare diseases, in part because the regulatory hurdle is low. And so I guess it shouldn't be surprising that when faced with a calamity, we don't have a system in place, as Dr. Califf notes, for pragmatic randomized controlled trials. And I guess just to make another point, since I'm Epi Biostats, I guess I should point out that there are some really good methodologists who are working on, I think, better observational ways to assess causality for drugs in real-world observational use data sets. And I don't want to take anything away from them, but I do want to acknowledge that the best sort of studies we have to date show marked disagreement between even propensity score matched analyses and randomized trials for therapeutic drugs on the same clinical question. So I guess I would say that I think sort of the status quo in drug approval is made itself evident in COVID-19. And so now you see 10 years of drug approval sort of history happen in 6 months. And we still to date do not have a single therapeutic that statistically significantly improves all-cause mortality in this highly lethal condition. And that to me is a tragedy.
Rob, any reaction to that?
Yeah, I mean, I think it's always fascinated me how there's a great editorial called "Kick the FDA, America's Favorite Sport." I think remember the history here is that prior to 1962, there was no requirement for efficacy of drugs, and in fact, there was even a drug on the market for teenagers whose mothers were going through menopause, and the drug had opiates in it. It was on the market. And the only proof that you needed that it was effective was that the doctors said it was effective. That was the standard. After thalidomide, Kefauver-Harris was passed, and I wonder whether the medical establishment would have ever gotten anywhere if not for the federal requirement that you prove efficacy. So, I mean, the FDA is a big hammer that can be used, but I just want to keep turning this back. You can pass a law requiring things, or the medical establishment could actually do the right thing. Yeah. And I think in this instance, where let's say you have a type of cancer where there's no effective treatment, I don't think cancer patients would say, let's wait 5 years for the full survival trial to be done. But you need a system where if that thing gets on the market, why don't the UCSFs of the world get their act together and do the post-market studies in a way that brings the answer home? There's a lot of capital in the pharma industry, but the medical care delivery system is many times, maybe even 100 times larger in terms of its financial impact. And there are many biases. One of the chief ones, which is in cancer, if you give the expensive chemotherapeutic agent, you make a lot of money.
Mm-hmm.
So who wants to get the answer that it may not be better than the generic? There may be disincentives in our own healthcare system that prevent this from being done, even if a company sort of wanted to do it.
Yeah.
Can I just add one thing there? Sorry, just real quick about the speed, because this is a paper that I actually published in Dr. Redberg's journal. We've gone to great pains to estimate how much time is saved by using surrogate endpoints in cancer medicine. And because cancer is highly lethal, just as COVID is highly lethal, the time savings, I think, has been markedly overstated. We find it's just about 11% of drug development time, and on the order of months, less than a year. And so I think that that's important to know in terms of the uncertainty speed trade-off.
Right. Rita?
I was going to second Vinay's point about, we've rejected so many observational studies on hydroxychloroquine, et cetera, and thinking, why didn't, we have over 2 million cases here, why didn't we just randomize? We would have had the answer. But I do think the FDA has a role, because the FDA issued an emergency use authorization for hydroxychloroquine, right? If the standard for getting a drug on the market was randomized data, we'd see a lot of randomized trials. The problem is the FDA does not require randomized data for drugs and devices. It's the rare drug and device that gets on the market after a randomized double-blind trial with clinical endpoints. As Vinay just said, a lot of drugs and devices are now on with surrogate endpoints, with observational data, with a lot of fancy. I think real-world evidence is great, but you have to have the randomized double-blind trial, and the FDA does play a role by what the standard is for approval. And I think most of us it has been lowered.
All right, let Rob, actually, before Rob reacts to it, Rita, Rob has also said part of it is we're not shining a mirror on ourselves, that we are not doing the trials that need to be done, and we are not doing the post-market surveillance when we're taking care of most of the patients. What do you think about that?
I mean, I think there's a lot of interest in doing the trials, but I think they're also, most in research now is industry funded, and understandably, it's a lot cheaper to do a trial that's not randomized double blind. And if FDA allows your drug on the market without that evidence, I don't think that we're going to see those kind of trials.
All right, Rob?
Yeah, so first of all, I just point out the FDA operates under the law. If there's one thing that's true about the FDA, and Rita knows this, it's full of civil servants who actually follow the law. So if we want to change some of this, we have to elect different politicians. All right. And the second point I'd make, I'm just astounded by, Rita, I really am, by your unwillingness to admit that there's actually a problem in the medical profession here. I mean, people that do clinical trials and participate are not just pawns of industry. They actually could do their own studies in systems like UC, which I don't know what the annual revenue is, but it's many, many, many billions of dollars. So yeah, I agree with what you said. I would actually like to see more requirement for randomization. I'm a randomizer by nature, and I believe ultimately you get the right answer more quickly if you randomize. But simply saying, well, the FDA should do this, I think is a pretty easy out relative to really confronting the demon in your own house.
I didn't say the profession didn't have a role, but I do think that the FDA has a big role too.
Feels like one of those where the system is getting the results that it's sort of designed to get. And so there's clearly part of it that is owned by the health systems, and part of it relates to the incentive system the health systems operate under and individual faculty operate under. It's hard to change everything without that incentive system evolving. And as I think Rob says, we own some of that. So it's an important point. I want to move on to a couple other areas that are coming up. What went wrong with the Surgisphere, New England Journal, Lancet fiasco? Anyone want to take that on? Are there general lessons there that we should, because we talk about, oh, you know, preprints and Twitter and this, and they didn't have peer review. Well, here is, you know, here is the best peer review, we assume, in the Lancet and the New England Journal, and this makes it out, and they're, you know, high profile articles that have to be retracted a month later. So anybody want to talk about the pathophysiology of this and the lessons?
I guess I'll say a few things. I guess I would say that, and I'm not labeling this particular study, but in general, for studies where there is a suspicion that at least some of the data, or perhaps all of the data, is fraudulent, peer review is a very blunt tool at identifying that. I think peer reviewers often don't have access to the primary data set. They don't have the ability or perhaps skill to run or replicate analyses. They're not always sort of data sleuths or data detectives. Peer review, I think, is built on the foundation that people submitting articles have done a good faith effort in having truthful and honest data points inputted into those articles. I think some of the things about this paper that might or did generate, I think, an early red flag were a number of researchers pointed out to just the sheer volume of data that this company had collected in a very short period of time. In some early accounts, it was 100-fold greater than other published papers at that time. The company had a very limited track record of having published any paper with this obviously impressive data set that, you know, if it were to exist, if it is to exist, it would have been really massive. And then I think the other questions that come into it are, what is the role of the first and corresponding author, who's often an academic, not part of a for-profit company, in terms of ensuring the integrity of the data? And but I do think that there were a number of red flags, but I am also forgiving to the fact that some peer reviewers, because of lack of skill or time, and because of a trust in the system, might not have found it.
So in some ways, the misplaced trust, was it mostly on the part of the senior authors who basically accepted this data set on face value without diving into it themselves?
I guess if we held people to the standard of PIs and corresponding authors having done the data analysis themselves, I would say many, many, many randomized controlled trials published in highly influential journals would have to have different authorship. So because of the industry runs, I think, the majority of the trials and does the analytical work. So I guess I'm not sure that you can even have a system that will eliminate fraud. I mean, I think we can work on hype, we can work on spun results, but fraud is a very challenging problem to get rid of in biomedical publishing. But I'd be curious what others think.
Yeah. Any other thoughts on this?
I thought Vinay made some really good points. I would just add, though, that to me, this is a lot like medical errors. It's a Swiss cheese phenomenon. So yeah, the senior authors, you know, had a problem. They should have done more work to understand the provenance of the data. But the journals also have a major responsibility, and you know, to argue that they were just naive. These are our top journals. It's not hard when you see a data set this big to ask a couple of questions that are kind of obvious.
Yeah.
Like, how did you actually get this data? Can you show me the trail of provenance on the data? It would have exposed the problem right away. So I think there's a lot of accountability here. I also want to comment on what Vinay pointed, which I think is really, really important. You wouldn't expect a average clinical professor to be able to take a data set from even a randomized trial, which is highly ordered, and do a competent analysis on it. That's why we have professional biostatisticians and epidemiologists. It's a team effort. And so the standard for most papers is that someone else does the analysis, you look at the printouts and do the best you can. But that means that you need to assure yourself that that trail of data and analyst is competent. And we need to work on that. The last thing I'd say, this gets to the authorship thing. I don't know what happened in this writing, but I often wonder how often the person who's the first author actually wrote the paper. Yeah. Because you do make attestations in that that are really important. And I'm dying to do this study. I wonder what Rita thinks about it. But one great use of AI would be to look at people's writing and then go back and look at their papers and see who actually wrote the paper. I bet you'd find there are a lot of people in high places that actually didn't write the paper.
That's a great idea. Rita, any comments?
I would like to say I agree with everything Rob said on this round, and we could do that at Verily. But I do think you're right, Rob. I mean, it's definitely the responsibility of the journals. And again, coming back to peer review where we started, peer review is really important, but it's not just the reviewers, it's also the job of the editors. I mean, and there were some red flags, as Vinay said. That was a huge database that I'd never heard of. I mean, that article had come in, we had an article from that database and looked at it and thought, I never heard of this database. We didn't, it didn't go further for other reasons, but you do, hindsight is easy and nothing, but that was a very large number of patients from a database we never heard of. So those were kind of things that, but again, I think we're in this era where there's this great rush to publication, and that I'm sure how to roll.
Yeah.
Bob, one thing just and Rita knows this well because she studied it. I know Vinay has too. One important thing, let's assume we get the dial right that you talked about as it relates to FDA. A really big thing about the FDA is it actually by law gets a copy of the raw data. And no other regulatory agency in the world does that. It's a really, really important global public service the FDA does. And you wonder if journals did that more often, whether we might end up in a different place.
Yeah.
I can't tell you how often what's in the raw database differs from what's in the journal.
But are you saying, Rob, you can imagine we get the raw data. Are there actually people that will pour through the raw data? You have enough bandwidth at the FDA to actually use it as opposed to it sitting on a shelf somewhere?
Oh, yeah. That's why there's 17,000 people at FDA. Most of them are involved in that process. They actually do their own analyses. And I think as Rita and Vinay pointed out, that won't fix it if you didn't have a control arm.
Yeah.
But it's why fraud is harder to do when it's FDA regulated research, because the best way to detect fraud is not by aberrant data. It's actually the data looks too good.
Right, and it's as Vinay was saying, it's sort of a Bayesian problem in a way. The pretest probability that some company you've never heard of has a database that's 100 times bigger than anything anybody has in the universe is close to zero. And so you really have to be in the mode of, we just want this paper out there fast to be able to not look at it carefully and say, ask some hard questions. George, did you want to add anything?
I mean, it's, I'm glad you brought up Bayesian analysis. We'll let that sit.
I'm trying to listen and learn.
Yeah.
We're running out of time. I have to ask Rob, and maybe others will comment on this, the last question. Sometime in the next 4 to 6 months, the FDA is going to be presented with data on vaccines. And, they're from 5 different vaccines, and maybe it's not going to quite reach statistical significance because they were done in a region that didn't have an outbreak and there just weren't enough patients, but there's a hint that it works. If you were still commissioner, how would you be anticipating what this extraordinary, sort of planetary decision that the FDA and other regulatory agencies are going to have to make about whether a vaccine gets the green light? You're on mute. Maybe that's the way you want it.
No, I love it. I used to run intensive care units where you make decisions about individuals, and making decisions is really important. I think this is maybe one of I don't know, 1 or 2 times in history where the FDA commissioner actually probably should have a role. Because remember what I said before, for routine product decisions, it historically has almost never gone to the FDA. There are only a couple of times to the commissioner. There are only a couple of times in history where that's happened. And so the commissioner's main job in individual product approvals is to protect the civil servants from the political influence. But there's no way around the fact that, much like accelerated approvals of drugs for rare disease where there's no treatment, in this case, we're going to have preliminary evidence. Right, it may not be conclusive, and there may need to be more studies, but depending on where the epidemic is and what the public health considerations are and the global politics, there's just no way around. This is going to require articulation of many points of view into a decision about how to proceed. I'd also point out there is a chain of command. I didn't know about this until I got involved in a controversial decision with Sarepta. Literally, the president could say tomorrow, approve this drug. It is an order from the president. The FDA commissioner reports to the secretary of HHS, who reports to the president. And that is a chain of command. And so, and then finally, I just remember that the law instructs the FDA that the criteria for approval is based on the opinion of experts in the field. And I want to just come back again to my theme for today, which is I love talking about FDA, but the biomedical community has a huge responsibility here to see if a consensus can be reached about the science, which would then inform the politics.
Yeah, that's a little scary if you think about the potential politicization of this issue, as we've seen that, politicization of masks and everything, things that are easier decisions than what this will ultimately be. I mean, is that the fact that it goes to the FDA commissioner and he or she, in this case it would be he, would have to be involved, does that feel like a good thing or potentially a bad thing because of the politics?
Well, in my way, if I were in the seat now, what I would do is to say, I don't want to be involved at all unless the relevant center director says, we need your view. In other words, if it's a clear-cut decision one way or another based on the science, there should be no place for the politics in it.
Yeah.
And the commissioner should protect the scientific decision. But if it's in the gray zone and someone has to make a decision and it's not a purely scientific decision, I don't see a way around it. And I think in that case, the commissioner really, I think, will have a vital role to play.
Yeah. All right. Let's take a couple minutes, see if anybody else has comments on this one. It strikes me as the gray zone strikes me as potentially more likely than not. If you think about
I agree with that.
if you wait another year, maybe the gray becomes clear, but you don't have another year. So any other thoughts on this, George?
Yeah, Rob, let me ask you a harder question.
Harder.
Would the FDA get involved in approving the Chinese vaccines?
Yeah, I mean, FDA routinely approves drugs that are never studied in the United States. When I say routinely, it's infrequent, but the FDA mandate does not say studies must be done in the U.S.
AstraZeneca is being done in Britain. Yeah,
We're only 4% of the world's population, so it goes to stand for a disease that's going to impact 7 billion people immediately, or a therapy. The studies may be done elsewhere, including China.
Yeah. George,
This morning,
go ahead.
No, I was just going to add, this morning, Moderna put out their press release that they are launching in July a phase 3 randomized controlled trial of 30,000 participants, primary endpoint symptomatic COVID, secondary endpoint severe COVID, and acquisition of SARS-CoV-2 virus. So I think, to your point, I am very worried that the result might be gray. What if we don't meet statistical significance for a primary endpoint? What if we just have a secondary endpoint? What if the endpoints don't all align? I mean, we're hoping for the best case scenario, a slam dunk successful vaccine. But in those cases of ambiguity, I think it's going to be a very tough decision, and making it in an election year in a political context, I think is a huge recipe for a challenging decision.
But assuming we haven't seen terrible harm in the studies to date, are you bothered by those secondary endpoints? If you don't get to mortality, but you just prove that the rate of hospitalization goes down and the rate of ICU use goes down and the duration goes down, wouldn't that be good enough to have me want to get one in my shoulder?
That would be terrific. But what if you only show that acquisition of virus based on PCR is improved? And what if not everyone in the study underwent ascertainment of the endpoint? And what if we're nearing an election and someone wants to show that they have developed a successful vaccine? And what if that empowers or makes people feel protected and confident in a way that's a false reassurance? So I think it's going to be, something super heated if it comes to that.
I'm guessing it will be. George, any comments on that? No, Rita?
The dial.
I just add, I think there is going to be incredible pressure to approve a vaccine. And I still remember swine flu vaccine that we were all mandated to get with great hope. And then it got, because the vaccine is going to go to millions, it got pulled off the market because Guillain-Barré was much more a problem than the benefits of the vaccine. So
Yeah.
I think that it's going to be really important to stick to the science, and there's going to be a ton of pressures that we've talked about in the last hour that are going to make people want to not stick to the science.
The thing I think we can all agree on is if a great set of studies are done that provide definitive answers, then the decisions are easier. So what would make my day is if Bob and Vinay and Rita and your various venues were out there recruiting people to get the trials done with the largest sample size possible in as short a time as possible.
I think we do that here.
We will take that as our mandate. Thank you. All right, we need to quit. Thank you, everybody. This is fascinating, unbelievably interesting. I don't know, Rob, whether you wish you were FDA commissioner now or you're thrilled you're not.
That was the best job I've had. I love the job I'm in now, but that was really a great job. And, I'd gladly go back if I could. It was a great time.
All right, good. All right, thanks, everybody. Really appreciate it. For our audience, as I said, this will be up on YouTube tonight at about 7:30. There's the members of our crack production team that pull this off every week. We'll be back again next Thursday, assuming we have something to talk about in COVID, which I think is a reasonably good assumption. And we'll keep doing it until we don't. So thanks, everybody. Have a great day, and see you next week.
Thanks, Bob.
Thank you.
Thanks.